Assalamu alaikum and good morning everyone. I am Dr. Durre Furkani and my moderator is Dr. Tanzil Gazdar. My topic of presentation is diagnosis of bladder carcinoma. Here are some learning objectives. Clinical picture, cystoscopy, then urine cytology, molecular markers, screening of population at risk, TUR, then imaging studies, then we will talk about the new technologies. Starting from the clinical picture, a patient with bladder carcinoma will present with gross painless hematuria, and it is the most common finding. And it is primary symptom in 85% of the patient. It will be intermittent and related to Valsalva maneuver. 20% of the patient with gross hematuria will demonstrate the urological malignancy, and 12.5% of those patients will have bladder carcinoma. A history of smoking or occupational exposure is usually relevant. Some patients will present to you with microscopic hematuria, and 4.1% of those are having the risk of bladder carcinoma. Visible hematuria is associated with high stage of the disease. To diagnose the carcinoma in situ, they usually not present with the gross hematuria. Maybe there is microscopic hematuria and associated with LUTs, especially irritative voiding symptoms such as frequency, dysuria, or urgency. So any hematuria, any episode of gross hematuria, even subsequent urinalysis is negative, should be evaluated. Advanced bladder carcinoma may present with lower limb swelling due to local extent of the disease. With metastatic, if there is deposit, it will present with bone pain. There may be history of weight loss, anorexia, or the anuria if bilateral ureteric orifices are involved and there is chronic obstruction. The sign you will assess on the physical examination will be pallor due to blood loss, secondary to hematuria, or if there is picture of chronic obstruction, so it will be also present with the pallor. History of weight loss, secondary to tumor, suprapubic mass could be palpable or pelvic mass, and if it is metastatic disease, then you can appreciate enlarged lymph nodes. Starting from the diagnostic modalities, ultrasound is the image mostly when we encounter patient with the hematuria. Ultrasound may be performed as adjunct to physical examination. It has moderate sensitivity abnormalities of upper and lower genitourinary tract. The sensitivity is 73% and specificity is 82%, and I am talking about the ultrasound CDI of the patient. It permits the characterization of renal masses, detection of hydronephrosis, detection of intramural bladder masses, but it cannot rule out potential causes of the hematuria and especially carcinoma in situ. It is unreliable in determining the deeply infiltrating disease and nodal involvement. So this is picture of ultrasound image. You can appreciate the growth from involving the left lateral wall and right lateral wall, and then very tiny growth you can appreciate at base of bladder. It is the other image, and it is showing the growth from the base of the bladder, and it is having sensitivity of 73%, means 27% of the tumor you can miss, and specificity is 82%. Then coming on to cystoscopy, the diagnosis of bladder cancer ultimately depends on the cystoscopic examination of the bladder. It is gold standard test for the evaluation of the bladder growth. Bimanual examination of the bladder should be performed under anesthesia before painting and the draping of the patient. The location, number and morphology of the tumor should be recorded. Urine for cytology is obtained as baseline to establish the likelihood of the high disease. Complete visualization of bladder is planned by either flexible cystoscopy or 70-degree rigid rod lens. Here it is image. Every part of the bladder should be evaluated. Trigone, dome of the bladder, lateral walls and base of the bladder should be examined so that you cannot miss any abnormality. Coming on to urine cytology, it is a technique which was introduced by Papineau-Nicolau in 1945. It is based on the idea that any abnormal cell or the tumor cell, you examine that under the microscope. The examination of voided urine or bladder washing specimens for exfoliated cancer cells, it is useful as adjunct to cystoscopy, almost reaching the sensitivity of 100% when you combine urine cytology with the cystoscopy. It is high sensitivity for grade 3 and high grade tumors, almost 84%. Low sensitivity in grade 1 and low grade tumors, 16%. So the sensitivity for detection the carcinoma in situ is 28 to 100%. Again, it is user dependent. If the cytopathologist is looking for any abnormal cells, then it has very low sensitivity. If he is looking for specifically the tumor cells and he is ignoring the other abnormal cells, then its sensitivity could reach about 100%. Overall sensitivity is 49% and specificity is 96%. Any patient with urine cytology positive for the carcinoma, it is highly specific for the diagnosis of bladder carcinoma or upper tract tumors. So cytological examination is user dependent. It is in experienced hand, specificity exceeds about 90%. There are certain limitations for the urine cytology as it is user dependent. I already mentioned it. Evaluation can be hampered by low cellular yield and UTI, which can distort the shape of cell and it will look like any abnormal cell. Then stone, same mechanism. So you look for any abnormal cell. Here you can appreciate the normal slide of the cell, and you can cells are nucleus are regular in shape, and on the left image you can appreciate the hyperchromatic nuclei with eosinophilic stains. Talking about the urinary molecular markers, these are the enzyme-linked immunosorbent assay tests for the tumor-specific urinary markers. They have sensitivity usually higher and again low specificity. They cannot replace but can be used adjunctively to improve the specificity. Two types mostly, the protein-based tumor markers, nuclear matrix protein 22 and the BTA, bladder tumor associated antigen. Then other are cell-based. There are the Eurovian, the FISH and immunocyte. NMP2 nuclear matrix protein is shed into urine of bladder cancer patients. It has sensitivity of 70% and specificity of about 75%. When combined with cystoscopy, it increases the detection rate of the carcinoma, and almost 96% it detects the bladder carcinoma when combined with the cystoscopy. Bladder tumor antigen detects the complement factor H related protein, which is secreted by tumor cells. Increased Lewis antigen X expression in urine of bladder carcinoma. Normally, antigen X, Lewis antigen X is not present in the urothelial cells. But when there is bladder cancer, the cell will express the Lewis X antigen. CK20 and CFRA21.1, these are the fragment of cytoskeletal proteins which are excreted in the bladder cancer patients. And then you can appreciate at the bottom the image BTA stat, this stat kit. This is qualitative test for the detection of the carcinoma. Talking about the fish, fish identifies the fluorescently labeled DNA probes that binds to intranuclear chromosomes, and it detects neuploidy of chromosome or loss of regions of the chromosomes. Fish analysis is moderately useful for high-grade disease and anticipatory of the new tumor formation. The median sensitivity is 79% and specificity is 76%. And if you add with the cystoscopy, you can reach sensitivity and specificity of about 94 to 95%. Post BCG, if fish is positive, then chances of recurrence are higher. Immunocyte is 3 monoclonal antibody labeled with 2 fluorescent color. It detects mucin-based antigen expressed in the tumor cells. The sensitivity is 61% and specificity is 71 to 100%. This is fish technology. It exploits the idea of one DS strand can complementary hybridize to the other DNA strand. The fish probes, these are basically short segment of DNA probes and they are fluorescently labeled, and the DNA strand is heated, so the denaturation of protein occurs and the strands they separate. That separated or denatured DNA probe, then there is abnormality. Sorry, if it cannot bind, then there will be abnormality. If it is able to bind, then it is normal strand. So it exploits that idea to rule out any abnormality if chromosome has. Potential application of markers and cytology. So they are basically uses for the screening of population at risk. They are mostly the patient at high risk. Primary detection of bladder carcinoma and surveillance of non-muscle invasive bladder disease. Talking about the screening of population at risk, routine screening for bladder carcinoma in general population with either urinalysis or cytology is not recommended. The application of hematuria dipstick followed by nuclear matrix protein 22 or Eurovision test if dipstick is positive has been reported in bladder carcinoma screening in high risk population. Incidentally discovered hematuria should never be neglected. Transurethral resection of Ta-T1 bladder tumors. The goal of TUR in Ta-T1 bladder carcinoma is to make the correct diagnosis and completely remove all the visible lesions. Bimanual examination should be performed under the anesthesia. Complete visualization to plan the resection is facilitated by either flexible cystoscopy or 70-degree rigid rod lens. Resection is performed by 30-degree lens placed through a resectoscope sheath. Fixation or persistence of bladder mass after resection suggests locally advanced disease. Resection is performed piecemeal, delaying transaction of the stalk until most tumor has been resected. After all visible tumor has been resected, an additional pass of the cutting loop or cold cup biopsy should be taken. Anterior wall tumors and tumors at dome of bladder can be resected by manual compression at the suprapubic area because these are the areas which are difficult to reach. Care must be taken during the resection near the ureteric orifice. Pure cutting current causes the minimal scarring. Orifice, if there is suspicion of involvement of tumor by at ureteric orifice, you should use the cutting current, and it causes the minimal scarring. So subsequent hydronephrosis, chances of blocking the kidney and causing the hydronephrosis will be minimal. If tumor appears to be muscle invasive, biopsies of the bladder and base to establish the invasion. Traditionally, TUR has been performed in the sterile water. Resection of diverticular tumor present a significant risk of bladder wall perforation, and accurate staging is difficult to achieve. Low-grade diverticular tumors best treated with combination of resection and fulguration at the base. High-grade tumors require adequate sampling of the tumor base so that you can easily stage the disease, and further subsequent management will be partial or radical cystectomy should be strongly considered for high-grade diverticular lesions. Right, sir. So moving forward, high-grade tumors require adequate sampling at the tumor base. Partial or radical cystectomy should be strongly considered for high-grade diverticular lesions. So, evaluation of the resection quality. The absence of detrusor muscle in the specimen is associated with high risk of the residual disease and tumor understaging. The presence of detrusor muscle in the specimen is the surrogate criteria of resection quality. So, role of the random biopsies. Biopsies of any suspicious area are an important part of the complete evaluation. The use of random biopsy to identify the carcinoma in situ in otherwise normal appearing mucosa is controversial. The random biopsies are indicated only in the setting of multiple tumors or positive cytology with normal looking mucosa. If in patients with positive urine cytology or with history of high-grade, grade 3 non-muscle invasive bladder tumor, mapping biopsies from the normal looking mucosa is recommended. Prostatic urethral biopsies. Any visible abnormal area at the prostatic urethra. If tumor is located at trigone or the bladder neck. In cases of high-risk patient where neobladder creation is anticipated, and in case of multifocal tumors, and we take it with resection loop near the verumontanum at 5 and 7 o'clock position. Repeat of transurethral resection of bladder tumor. Repeat TUR is indicated if high-grade tumor is identified. When repeat TUR is performed with several days to weeks of the original resection, residual tumor is identified at initial resection site at least 40% of the time. Repeat TUR is indicated in the evaluation of T1 tumors, especially if no muscle is identified on the initial pathology. Sometimes you have to do the partial resection when it is not possible due to high volume disease, anatomical inaccessibility, or the risk of perforation. So you do the repeat TUR of bladder cancer. Impact of second resection on the treatment outcomes. A second TUR can increase the regression-free survival, and level of evidence is 2A. Improve outcomes after BCG installation, level of evidence is 3. And provides prognostic information, and level of evidence is 3. When to perform second resection? Retrospective evaluation showed that resection performed 14 to 42 days after initial resection provides longer RFS progression-free survival compared to the resection performed after 43 to 90 days. Second TURBT is recommended in selected cases 2 to 6 weeks after the initial resection. Coming on to the imaging modalities to further diagnose the bladder carcinoma, imaging studies of the upper urinary tract are integral part of the hematuria workup. CT scans of the abdomen and pelvis with contrast are recommended. It has been reported sensitivity of 85% and specificity of 94% for diagnosis of the bladder carcinoma, but CIS, flat lesions and tumors less than 1 centimeter are more likely to be falsely negative. It allows the visualization of the extravesical spread, but due to inability to distinguish the muscle layers of the bladder, it is not reliable in determining the locoregional disease. Here it is CT image, and you can appreciate this is transverse section, and you can appreciate the growth at the right lateral wall. Again, another image here, growth is present at the base of the bladder. Talking about the MRI has excellent soft tissue resolution and multiplanar capabilities. It is important diagnostic modality in local staging in selected patient population in which CT is relatively contraindicated, like pregnant patients or patients with renal failure or patients having the contrast allergy. On T2 weighted image, in conjunction with gadolinium contrast, MRI has accuracy of 85% in differentiating non-muscle invasive bladder carcinoma from muscle invasive bladder carcinoma, and 82% accuracy in distinguishing organ confined disease from non-organ confined disease. Diffusion weighted MRI is more sensitive and specific than the conventional MRI in detecting the higher stage disease with specificity of 98% and sensitivity of 92.5%. However, due to limited resource, CT is still more commonly performed to stage the disease. These are some images for MRI, and here this is CT image, and then MRI image showing the growths at the base of the bladder. Role of PET CT. Composite PET CT images provide three-dimensional whole body structural and functional information. 18-FDG is currently the most commonly used PET tracer in oncological imaging. Better in identifying the extravesical disease like lymph node status, distance metastasis than the primary lesion, because concentration of FDG in the urine obscure the bladder imaging. The sensitivity and specificity of 18-FDG PET CT for staging or restaging of bladder cancer is 82% and 89% respectively. In clinical setting, it is not used as principal staging modality. Currently, C-choline is under investigation and the trials are underway to further see the results. Now we talk about the new methods of tumor evaluation. Talking about the fluorescent cystoscopy, photoactive porphyrins, 5-aminolevulinic acid and hexaminolevulinic acid accumulate preferentially in the neoplastic tissue. They are 20 times more than the normal cells. So they emit the red fluorescence, which you can easily appreciate with the blue light. Indications are an unexplained positive cytology, history of carcinoma in situ, high-grade disease with sessile appearing growth. With this technology, both small papillary tumors and almost 1/3 more cases of CIS overlooked on cystoscopy are identified. Fluorescence guided cystoscopy and dissection are more sensitive than the conventional procedures. Meta-analysis shows that 20% more tumor-positive patients were detected in non-muscle invasive bladder carcinoma and 40% more in carcinoma in situ groups. Residual tumor after the resection were significantly less. This is image of the wide light cystoscopy. You can easily see that there is normal looking mucosa, but on the fluorescent cystoscopy using hexaminolevulinic acid, there is lesion you can appreciate. And so again, this image, and you can compare both of them, and in this ALA contrast is used. So again, there is papillary growth, but you can easily miss that lesion in wide light cystoscopy. Narrowband imaging. Narrowband imaging is optical image enhancement technology intended to improve the visibility of blood vessels inherent to the neoplastic process. It is based on the phenomena that depth of light penetration increases with the wavelength. White light is filtered into two bands, blue and green spectrum. The contrast between normal urothelium and hypervascular cancer tissue is enhanced. Narrowband imaging light is composed of two wavelengths, which are blue and green, and absorbed by the hemoglobin. 415 nanometer light penetrates only in the superficial mucosal layer, enlightening the capillary network, while 540 nanometer penetrates more deeply. This is the mechanism. White light is filtered into two spectrum, blue and green. Blue has the wavelength of 415 nanometer and the green has wavelength of 540 nanometer. Then color adjust, with color adjustment you will get the image. And this is again another picture depicting the mechanism. The blue light, it only illuminates the superficial layer, mucosa, and the green light penetrates more deeply. With increasing wavelength, the deep tissue can be illuminated. So this is the image, real-time image. You can see this is the image of white light cystoscopy, and this image uses the blue and green spectra, and you can specifically see the blood vessels running through the mucosa and submucosa. Then STAR's Professional Image Enhancement System, SPICE. It digitally enhances the wide field image of the bladder surface, allowing urologists to choose the best enhancement method in different clinical situations. It can be used with blue light cystoscopy to enhance the sensitivity and specificity. With this technology, we can assess the depth of tumor invasion. Early experience suggests that SPICE has similar detection rate to NBI regardless of the tumor stage. But advantage is you can get 4 types of the images, and you can easily see the depth of invasion at the time of resection. These are some images. On the topmost, you can see that this is white light cystoscopy, then photodynamic images with dyes, and then narrowband imaging. This looks like that. And with SPICE, you can appreciate and you can see the difference of the images. OCP, optical coherent tomography. OCP provides high resolution cross-sectional image of the tissue structure to depth of 2.5 mm. It is analogous to ultrasonography, except that it uses light rather than sound, achieving an image resolution of 1 to 5 micrometer, that is 10 to 100 times higher than the ultrasound. It provides not only comprehensive visualization of tissue morphology, but allowing tissue dynamics and biochemical properties to be studied. These are some images from OCP technology. You can easily appreciate the between different layers, from normal urothelium to lamina propria and then muscles. You can easily assess each layer, and then you can assess the tumor if there is any. So this concludes my presentation. Thank you so much.